In a debate that is gaining urgency across the medical community, leading plastic surgeons are now calling for a pause on gender-affirming surgeries for minors, arguing that the science guiding these irreversible procedures is far from settled. This renewed scrutiny follows statements from prominent figures within the American Society of Plastic Surgeons, urging doctors to delay surgical interventions until patients are at least 19 years old. Their reasoning centers on one key concern: the lack of long-term, high-quality evidence supporting early surgical transitions. At the center of this discussion is Dr. Sheila Nazarian, a board-certified plastic surgeon who has raised alarms about what she describes as a growing gap between ideology and science in modern healthcare. According to Dr. Nazarian, medicine must remain anchored in data, especially when procedures carry lifelong physical and psychological consequences. Supporters of the delay point to European health authorities, many of which have reversed earlier policies after conducting large-scale evidence reviews. Countries such as the UK, Sweden, and Finland have restricted or reassessed gender-related medical interventions for minors, citing insufficient long-term outcome data and concerns over patient regret. One of the most influential assessments fueling this shift is the CAS Review, a comprehensive evaluation commissioned by Britain's National Health Service. Its findings raised serious questions about the quality of evidence used to justify early medical and surgical interventions, particularly for adolescents experiencing gender dysphoria. Critically, the report highlighted that much of the existing research relies on small sample sizes, short follow-up periods, and observational data, factors that weaken scientific certainty. For surgeons, this matters. Unlike hormone treatments, surgery is irreversible. Dr. Nazarian and others argue that delaying surgery does not deny care, it preserves options. Adolescence, they note, is a period of psychological development, identity formation, and emotional volatility. Introducing permanent physical changes during this phase raises ethical questions that medicine has a responsibility to confront honestly. At the same time, critics of these calls for delay argue that postponing surgery may increase distress for some patients. But surgeons advocating caution counter that emotional urgency cannot replace scientific rigor. What makes this moment different is that these concerns are no longer coming solely from political figures or advocacy groups, but from within the medical profession itself. Surgeons, trained to weigh risk above all else, are asking whether current standards truly meet that threshold. This debate is no longer about access alone. It is about evidence, timing, and responsibility. And as this conversation grows louder, it is reshaping how doctors, parents, and policymakers think about the future of gender-related healthcare. As the debate unfolds in the United States, much of the momentum behind calls for caution is coming from overseas. European health systems, long viewed as progressive leaders in public medicine, have quietly but decisively changed course. In recent years, countries including the United Kingdom, Sweden, Finland, and Norway have moved away from early medical and surgical interventions for minors with gender dysphoria. These decisions were not driven by politics, officials insist, but by evidence, or the lack of it. The CAS review became a turning point. After examining years of clinical data, researchers concluded that the evidence supporting early gender medical interventions was remarkably weak. Long-term outcomes were unclear, and many studies failed to meet basic standards of reliability. One of the most concerning findings involved detransitioners, patients who later sought to reverse or regret earlier medical decisions. European health authorities acknowledged that these cases were underreported and poorly studied, leaving doctors without clear data on long-term psychological and physical outcomes. For surgeons like Dr. Sheila Nazarian, this lack of clarity poses a fundamental problem. Surgery, unlike therapy or counseling, permanently alters the body. Once performed, it cannot be undone. In medicine, irreversible action typically demands the highest level of proof. Another concern raised by European reviews was diagnostic uncertainty. Adolescents presenting with gender distress often also experience anxiety, depression, autism spectrum traits, or trauma histories. Critics argue that these overlapping conditions complicate diagnosis and raise the risk of premature medicalization. European regulators responded by tightening standards. Rather than fast-tracking interventions, They emphasized extended psychological evaluation, delayed medical treatment, and a presumption of caution, especially for minors. These shifts have not gone unnoticed in the United States. American physicians are increasingly asking why U.S. standards appear to diverge from those adopted abroad. If Europe is pulling back due to insufficient evidence, should the U.S. be moving forward? Dr. Nazarian argues that medicine must be consistent. Evidence accepted in one country should not be dismissed in another simply because it is politically inconvenient. She warns that when scientific debate is labeled as harm, open inquiry suffers. Supporters of current U.S. practices counter that restricting access may marginalize vulnerable patients. But critics respond that safeguarding patients also means protecting them from interventions whose long-term consequences remain unknown. At the heart of the issue is a single question: has medicine moved faster than the science? As European systems slow down and reassess, American doctors are now facing mounting pressure to justify why irreversible procedures should proceed without comparable long-term data. And that pressure is only increasing. By this stage of the debate, the focus has shifted beyond individual procedures to something broader: how modern medicine makes decisions when evidence, ethics, and ideology collide. Dr. Sheila Nazarian and other surgeons emphasize that questioning medical standards is not an act of hostility, it is a professional obligation. In every other area of surgery, new procedures undergo years of data collection, long-term follow-up, and peer review before becoming standard practice. Critics argue that gender-related surgeries for minors have bypassed that process. One of the most contentious issues is the role of institutional pressure. Some physicians report reluctance to voice concerns publicly, fearing professional consequences. According to critics, this environment discourages scientific debate and replaces it with consensus driven by politics rather than data. Medical organizations are now facing scrutiny over how guidelines were established. Surgeons are asking whether existing recommendations were based on strong evidence or on assumptions made during a period of rapid cultural change. Another unresolved issue is accountability. If long-term data eventually shows harm or widespread regret, who bears responsibility? Doctors? Institutions? Regulators? These questions remain unanswered, but they weigh heavily on practitioners being asked to perform irreversible procedures. Meanwhile, parents are increasingly caught in the middle. Many are seeking clarity, not ideology, wanting to know whether delaying surgery truly protects their children or risks emotional harm. Surgeons advocating postponement argue that time itself can be therapeutic, allowing identities to stabilize without permanent intervention. Policymakers are also watching closely. As European countries tighten standards, pressure is mounting on U.S. regulators to re-examine their own policies. The gap between international approaches has become difficult to ignore. What makes this moment significant is that the conversation is no longer confined to activist spaces or political debate. It is happening in operating rooms, medical journals, and professional societies. This is not a debate about compassion versus care. It is a debate about what responsible medicine looks like when certainty is absent. And as more doctors speak out, one thing is becoming clear: the future of this issue will be shaped not by slogans, but by evidence, transparency, and time.